Step 65, cycle review after frozen embryo transfer cycles. In human reproduction, you have a selection of best quality sperm and eggs and embryos, and this selection process is ongoing across all the milestones of fertility. So even after transfer of high-grade blastocyst embryo, generally speaking, you have 1 in 3 chance of success. Depending on your age, your success may be higher or lower, but generally 1 in 3 chance of success, 2 in 3 chance of failure. We think even in natural conceptions, high quality, high grade embryos keeps coming to the uterus, and generally we think 1 in 3 embryos implant and become healthy babies. But in frozen cycles, after failed embryo transfers, we should try and understand what could be the cause for failed embryo transfers. We can never tell whether this is due to embryo, due to uterus, due to hormones. It's impossible to tell, and there isn't any test. I don't think there will be any test in the future which can tell exactly why you had failed cycle. In order to understand that, we need to have an overall analysis of that cycle and the overall analysis of both of your fertility and your fertility treatment. That's called cycle level analysis and patient level analysis. So that will tell us what could be the possible cause. And although we don't know, but we should still analyze and understand what could be the cause of failed embryo transfers so that we can address that issue for future transfers. For that, first you need to do cycle level analysis. Cycle level analysis means analyzing your embryo transfer cycle from the beginning, from first day of your menstrual period, cycle monitoring and embryo transfer and luteal phase support. Try and understand if there's something wasn't right in that cycle. The second is you do patient level analysis, which I will explain later. In terms of cycle level analysis, you need to look at 4 big factors which determines your success in frozen embryo transfer cycles. First, your hormones. There are 4 hormones at play: 2 pituitary hormones, 2 ovarian hormones. You need to check your hormone levels from the beginning of your cycle. In terms of pituitary hormones, your FSH and LH, and then from ovarian hormones point of view, your estradiol and progesterone. They should work in concert, and their levels should match each other in terms of developing your follicle, developing your corpus luteum, and producing progesterone, which supports your pregnancy. That they need to make sense. Here, especially in a natural cycle, induced cycle, and stimulated cycle, we want a development of follicle that should produce estradiol first. Your estradiol should go up, then you should have a LH surge, or you should do the trigger. Then after the trigger or LH surge, your estradiol should drop. Then you should have a progesterone increase in progesterone levels. That's called progesterone shift. And if all this happening according to normal physiology, that means your hormone levels were optimal, and that give a right signal at right time for development of endometrium and for implantation. The second thing you need to check is whether your endometrium was optimal, because you will have ultrasound scan in the middle of your cycle, and during monitoring, that scan should measure the endometrium. Generally, we want endometrium to be more than 7 millimeters in size, and we don't want any fluid inside the endometrium. We don't want any structural abnormalities like uterine septum, uterine polyp, because fibroids. If your endometrium was optimal, then we assume that endometrium development was normal, at least for structurally. Then timing of your transfer. Implantation window normally stays open for 3-4 days. You should aim the transfer right in the middle of implantation window. For that, you need to get the timing right, especially if you had the ovulation in like a natural induced or stimulated cycles. You should time the transfer against the LH surge and confirm by progesterone shift, or if you're using the trigger, you should do the transfer 7 days after. That's right in the middle of implantation window. Then you need to evaluate the quality of the embryo which was transferred, whether this embryo you transferred was of high grade blastocyst, and if there was any issue with survival or expansion of the embryo after thawing. You analyze these 4 things. If all of these things were right, then you assume there wasn't any issue in the cycle level. then you start understanding if there is any issue in the patient level. When we say in the patient level, we need to analyze two big factors which determine success or failure in IVF. You have a baseline fertility that's determined by baseline health and age. Then you look at two big factors, embryos and uterus. In terms of all embryos you created so far or in storage, you analyze the quality of those embryos against female age, egg quality and quantity, and the sperm quality and quantity, and the overall quality of embryos you are producing. For example, if you're doing IVF and easily producing high-grade embryos, that means that most likely you don't have significant problems in terms of egg quality, sperm quality, and embryo quality. So most likely ploidy or chromosome setup of most of your embryos should be generally healthier than other women who is really struggling to produce high-grade embryos. So that's called embryo level or patient level analysis. Then you need to analyze in terms of your uterus. Is there any issue which is linked to the uterus which may be reducing your chance of implantation? That is really, for that you need to check whether you have adenomyosis by doing MRI scan, for example, or deep pelvic ultrasound scanning, or endometriosis. Maybe you need to do laparoscopy to check if you have a severe endometriosis, or check if you have a structural abnormality in the uterus, like endometrial polyp, submucous fibroids, uterine septum, or fluid inside the uterus, which may be causing problem with implantation, any structural problem on implantation bed. For that you may need to have ultrasound scan, MRI scan, hysteroscopy, or laparoscopy. Once you do this patient level and cycle level analysis, if you find any issue, you address those issues before you do transfer in the future cycle. Then you create treatment plan. You discuss with your specialist, and your specialist makes a plan in terms of if you don't have any more embryos, if you want to do fresh embryos, fresh cycles, then they decide whether your cycle need to be optimized. For example, if there was issue with any embryo quality, then they may need to optimize your cycle, changing your regime, FSH injections, trigger injections. Then they will decide whether the implantation need to be optimized. For example, if you have adenomyosis, that may need to be treated. Endometriosis, that may need to be treated, for example. If you want to do frozen cycle, if you have frozen embryos, then the protocol need to be optimized. If you are, for example, a natural frozen cycle, then you may need to be moved to stimulated or letrozole frozen cycle. Or if you're on HRT frozen cycle, then you may need to use one of other regimes or protocols for a frozen cycle. Then your specialist will decide with you together whether you need further investigation to check if there are any factors which is affecting egg quality, for example, severe endometriosis, by doing laparoscopy. If there are any factors which is affecting your implantation, like submucous fibroid, endometrial polyp, for that you may need to have a hysteroscopy. And also you look at the bigger picture to see if there's any lifestyle factors, any environmental factors or work-related factors affecting egg quality and sperm quality, and that needs to be addressed before going ahead with the next transfers. This is analysis of a frozen embryo transfer cycle. In the future, we will be discussing overall analysis of your IVF cycles. We will go much in deeper level to understand that.